Hello, everybody. Thank you for the opportunity to present today. So I'll be talking about the echocardiographic quantification of the right-sided chambers. I'd like to, first of all, thank the entire Echo Lab, the attendings, the sonographers, and the fellows and other residents as well for their support directly and indirectly in the creation of this presentation. But I don't have any disclosures. So it's an extensive topic, and so I'll be covering a portion of it during the hour that I have. We'll go over the guideline recommendations regarding the quantification of right-sided measurements. We'll discuss some limitations with respect to these measurements and how we can enhance image quality and accuracy. And then I'll dive a little bit into the future of right-sided chamber measurement and the role of AI in this respect. So the first guidelines in 2005 for the quantification of right-sided chambers was relatively brief. At that time, there wasn't enough data. And then in 2010, there was quite a bit more data that was available, and that culminated in a report that specifically focused on the right heart in adults. And so this will be one of the primary guidelines that I derive a lot of my presentation from. And in addition to that, the update in 2015 for the quantification of cardiac chambers, where there's additional data that's been provided to streamline assessment of the right-sided chambers. And so these are the two reference documents. So in terms of the background with respect to the right side, it's historically been neglected for numerous reasons. One of the reasons is that it has this unique crescent shape that makes it challenging to actually get measurements for. But in addition to that, we've often paid significant and enormous attention to the left side, for which we have ample data and studies to support its use. And so the goal of this is to kind of demystify the right side a bit and see what is promoted by the guidelines and how can we incorporate that into our practice. I'll cover the anatomy of the right side, and so it is unique relative to the left side. You have the superior vena cava, inferior vena cava that feed into the right atrium. You have the trabeculae carinae that are present in the right ventricle. You have the supraventricular crest, which is a muscular ridge that separates the smooth part from the trabecular carinae. And then you have the moderator band. And so these are some unique features of the right side of the heart that are worth noting and are important in actually identifying the right side when you're looking at echo. In terms of the coronary supply, the RCA is the primary supplier of blood to the right side, and so the more proximal an occlusion in the RCA, the more myocardium will be affected in the RV. And so it's just important to note that the marginal branches tend to supply more of the anterior wall, and then the posterior descending artery and the dominant RCA will supply the inferior wall. And then importantly as well, the LAD supplies both the apical septal regions, but also the moderator band. And so in LAD occlusion, you can get some ischemia of the moderator band. So as I mentioned, the RV has been sort of neglected in our standard TTE, partly because it's difficult to image. It lies behind the sternum, which puts it in an awkward position. The orientation and anatomy of the RV is complex relative to the LB. And the RV is obviously trabeculated, which makes endocardial definition difficult, and as a consequence of that, makes it challenging for us to be able to get accurate measurements. But it has an impact on cardiopulmonary outcomes. And we know that there's this interaction with left heart disease and pulmonary hypertension, patients with severe TR. And so an assessment of the RV beyond just visual estimation is important and necessary, and establishing tools to be able to do that is also important skill set. So in terms of the comprehensive assessment of the RV, we want to get estimation of the RV size and wall thickness, the RA size, various parameters for estimating systolic function, so the fractional area change, tissue Doppler S prime, TAPSE, the myocardial index, the 3D RVEF, and then strain, and then diastolic function, tricuspid valve and pulmonic valve morphology and hemodynamics, RVSP, intraatrial septum, and then a complete left heart assessment. For the purposes of this talk, I'll be focusing primarily on the first three, It's an exhaustive topic, and I'll refer you to other presentations where the others have been talked about already. And in terms of the images for a comprehensive assessment, everybody's already familiar with this, but it's essentially our standard protocol. So left peristernal long axis, or inflow and outflow views, or short axis, apical four-chamber, and then the RV focused apical four-chamber, modified apical four-chamber, and subcostal images. And for the purposes of this talk, we'll be focusing on these four. And it's important to try to use each view to add complementary information so that you can get a complete assessment of all the different segments of the right-sided chambers. Some important caveats before I begin about that is that normative values for the right side are not necessarily indexed to body surface area or height, except for RA and RV volume. And patients that are at the extremes of body surface area and height could be misclassified as a consequence of this. And so that, ends up being in the hands of the interpreting physician to make interpretations based on what they're actually visually seeing as well, as to avoid misclassification. And then also, there's not a lot of normative data that exists for congenital heart disease or endurance athletes. And so the above would also apply to them. It's just a quick question. Yazid asked me this a couple of weeks ago, and I didn't have a good answer for it. What's the difference between the LV and the RV, and how do you distinguish between the two? I don't want to spend too much time on this, so just general thoughts. Size. Tricuspid valve. So the positioning of the tricuspid valve will always sort of be above the mitral valve. In this view, you can't see it, but also if the presence of a moderator band, sort of your outflow views, you may be able to see that sort of crista, where it's sort of this difference between the smooth part of the heart and the muscular part of the heart. The trabeculae, depending on the patient, may be helpful. But often, if you're looking at size or wall thickness in a patient that has severe RVH or significant RV dilatation, you may actually get an apex forming RV, and so it becomes challenging to be able to interpret it just based on that. So you want to look for unique features that the RV specifically has to be able to distinguish that. So now going into the comprehensive assessment of the RV. So starting off with our long axis and peristernal view of the RV anterior wall. So this is useful to be able to assess for the proximal RVOT, and so we can get this linear dimension in this view. Again, this view, it's challenging in some patients to be able to get the appropriate transducer angulation, and so depending on the rib space, you may overestimate or underestimate the RVOT linear dimension. The rule of the thirds still applies here, so the RV, the aortic valve area, and the LA should approximate one another, and so it's sort of a rough estimation of whether or not the RV is enlarged. Then in the peristernal long axis, a view of the RVOT and PA, when you see fan down, you see the RVOT and its long axis, and the main PA is also visible, and so you can get sort of the distal RVOT measurement in this view. And you can get an assessment of the pulmonic valve. In the peristernal long axis RV inflow view, we don't do any specific measurements here, but just as a visual representation, you have your RA and RV, and so you can get a sense of obviously TR in this view, and then the relative size of the RA and RV. And then in your peristernal short axis, this is where we make measurements of the RV outflow tract, so the proximal RVOT and the distal RVOT in this view. You can also look for shunts between the LA and RA. The peristernal short axis bifurcation of the PA, so if you were able to sort of assess for the right PA and the left and get measurements of the PA in this view. And then in your peristernal short axis, the level of the mitral valve, what you're essentially looking for here is obviously you can appreciate the crescenteric shape of the RV in this view. But in addition to that, in patients with pressure or volume overload, you'll see sort of a T-shaped septum or septal shift. In your peristernal short axis, the level of papillary muscle, similar idea, you can appreciate the crescenteric shape and look at the different walls, the anterior, lateral, and inferior walls, and also appreciate if there's a D-shaped septum in the setting of pressure or volume overload. Your apical four-chamber view is important to be able to assess for RV inflow, TR. This is not the dedicated view to be able to look at the RV, so you actually want to make your measurements for basal diameter in an RV-focused apical four-chamber view. And so your basal diameter, your mid diameter, and your longitudinal diameters in this view, and try to get your RA measurements as well as fractional area change in this view as well. and then your modified apical foreshortening, which is more off-axis to make sure that you're not foreshortening. You can assess for ASD, PFO in this view. Then your RV apical 5-chamber view, you're able to appreciate the moderator band in this view, and so this is a helpful trick to be able to determine which one is the RV. And then if you were to fan more posteriorly, you can see the coronary sinus feeding into the right atrium. This is your coronary sinus view in the apical fold. And then your subcostal 4-chamber is where we make our measurements for right ventricular hypertrophy and RV wall thickness. And so this can be done by M-mode or 2D echo. You can also assess for ASD PFO in this view. And then in your short axis, the basal RV, similarly, you can look at the RV flow tract and get a sense of the RVOT dimension. We'll go over some of these measurements in more detail. So with the left peristernal long axis view, we're essentially going to appreciate the proximal RVOT diameter, which we measure from the anterior RV wall down to the interventricular septal aortic junction at the end of diastole. So this is relatively easy to get in most patients, but sometimes it can be obscured. You may not be able to appreciate the anterior RV wall. Some patients with a large amount of epicardial fat, it may be challenging to determine where exactly to start your measurement. This is dependent really on imaging plane and probe height. And so again, you may overestimate or underestimate the RV view, especially if you're obliquely oriented. And also if patients have chest or spinal deformities, that can also obscure your view. Getting a good endocardial definition of the RV is important here. And also there's limited normative data, and it's also still just a regional linear measure. And so you would want to take this within the entire clinical picture. And so the upper limit of normal here is 30 millimeters. And so anybody who has RV or LV dysfunction, it's important to try to get this measured. Next is in the short axis view at the level of the aortic valve. You get this additional RVOT proximal measurement, and then now you're also able to appreciate at the level of the pulmonic valve, you're able to measure the distal RVOT. And this is again at the end of diastole. This is also easily obtainable. It's part of our standard protocol. Again, if you're obliquely oriented, it will affect your measurements. Similar idea with chest or spinal deformities and limited normative data. The upper limit of normal here for the proximal RVOT diameter is 35 millimeters, and then for the distal, it's 27. And this is particularly important in patients that have congenital heart disease, so petrology, or patients that have ARVC, for example, in assessing the RVOT diameter, as this is part of the actual criteria for example, ARVC. In terms of the RV-focused apical 4-chamber view, as I mentioned, this is the ideal view to be able to get your standard measurements for basal RV diameter, RV area, and RV volume. And so it's important to try to ensure that you get the largest RV basal diameter. And so you want the LV apex at the center of your scanning sector. Try to avoid foreshortening. And minor rotations can actually completely change your image. And so this is reflected here, where you can see this your modified 4-chamber, where you sort of have obscured free wall over here of the RV, but in your RV focused 4-chamber, you have a much clearer understanding of your parameters. And here you can see that depending on where you slice in short axis, you'll get completely different images. And so if you were to sort of slice right in the middle, this kind of suggests that this crescenteric shape will provide very different results. If you slice in the middle, you'll get actually a much smaller basal diameter, versus if you're more oblique, you get the maximal diameter, it actually does change the basal diameter that you end up getting. So in terms of our measurements for RV basal, mid, and longitudinal diameter, we're trying to get the maximal linear diameter in the basal 1/3 of the RV at the end of diastole. And this is ideally in your focused RV view. Then the mid-cavity linear dimension is going to be somewhere in the middle third, halfway between the maximal diameter and the apex, so usually at the level of the papillary muscles. And then your longitudinal diameter will be from the level of the tricuspid valve annulus up to the apex. Often the difficulty I've seen is that we're not able to appreciate the RV apex well, and so I don't see the longitudinal measurement done frequently. But we're generally able to get the basal diameter reasonably well, reliably. Again, we may underestimate RV size and linear dimension depending on the probe and the quality of the image. So the upper limit of normal for the basal diameter, number to remember is 41. For mid, it's 35. And then for longitudinal, it's 83. And the other important factor here is that sometimes your measurements may be normal, but visually the RV may appear dilated. And so in those cases, we've talked about too is, you kind of want to provide data that's not going to misconstrue what you're seeing as well. And so it may be sort of a measurement thing in those cases. And so it's important to report the RV as appearing larger than the left in those cases. Moving on to 2D area. So for this, we want to manually trace the RV endocardial border from the lateral tricuspid annulus along the free wall to the apex and then back down to the medial tricuspid annulus at the end of diastole, and then again at the end of systole. Importantly, the difficulty here is often trying to include the trabeculations, the papillary muscles, and the moderator band in the cavity, especially when your image quality isn't good. That can be a challenge, but it can be easy to measure when the quality of the image is reasonable. Other things is that because of the nature of the interaction between the LV and the RV, your diastolic measurement may have to happen in a different tomographic plane than your systolic measurement. And so that's another important feature to remember, is that you may actually have to see whether or not you have to fan a bit differently to be able to get a good systolic measurement. Because depending on how the LV is contracting, it may actually completely obscure the RV. So this is reflecting that here. We have our end systolic measurement. We've traced around from the lateral tricuspid annulus along the free wall up to the apex and then down to the medial annulus in diastole and then in systole. And this is important because we use these measurements in our fractional area change, which I'll talk about shortly. So the upper limit of normal index to body surface area for men for the diastolic area is 12.6, and then for women it's 11.5, and then for systolic it's 7.4 and 6.4 respectively. So this kind of lends to establishing our 3D volumes, and so this is the technique is essentially to get multi-beat 3D acquisition. You want to get the minimal depth or sector angle. You want to, there's going to be auto measurements, but you want to verify those manually as well. And then you want to include the trabeculae moderator band in the cavity. This is useful because our 2D area excludes our outflow tract. And so this will still include our RV outflow, inflow, and apical measurements. And then this has been validated against cardiac MRI. You need a regular rhythm for this, good image quality, obviously, and operator training. And there's not many publications with reference values, and so it's still sort of in its beginning stages. But essentially, you're able to sort of produce this 3D image that then provides you with your end diastolic and systolic volumes, which can be used to compute your 3D LVEF. Sorry, RVEF. So in terms of your EDV, for men, the upper limit of normal is 87. For women, it's 74. For the systolic volumes, index of body surface area, it's 44 for the men and 36 for women. Moving on to the subcostal view, as I mentioned, this is the view to be able to get RV wall thickness. And so this is a linear measurement, either using M mode or 2D echo at the end of diastole below the tricuspid valve annulus. At a distance, approximately the length of the anterior tricuspid valve leaflet when it's fully open and parallel to the RV free wall. And so you want to exclude the papillary muscles, the trabeculae, and epicardial fat, so that can be challenging. And you want to ensure that respiratory maneuvers are being used to try to optimize the image quality, and zooming in may be a helpful strategy in this setting. This can be challenging if the visceral pericardium is thick, it's an oblique measurement. Again, it's important to know that there's no actual criteria for what is a thin wall. In ARVC, for example, a thin sort of free wall there is something that is part of the criteria, and so that's something to keep in mind. It's a limitation of this measurement, but anything above 5 millimeters is considered abnormal. Right atrial area and volume is also another important measurement that we can do at the end of systole prior to the tricuspid valve opening when the RA chamber is at its greatest size. And so this is gender dependent. Generally, men have larger atria. You want to avoid foreshortening in the dedicated four-chamber view. You want to trace the inner area of the RA and exclude the area underneath the tricuspid valve and the RA appendage. And then for this, the minor and major access, our upper limits are described there for men and women. And in terms of the RA volume, the upper limit of normal is 18 for men, and it's about 20. It's about I guess 16 for women. Now moving on to RV systolic function. So there's many different modalities that we can use. The amount of evidence we have for each I'll go through, but generally TAPSE or S prime, fractional area change, RV longitudinal strain, 2D and 3D echo are right index of myocardial performance, and then our pressure gradient with our TR jet. So with respect to these quantitative parameters, the ones that have some clinical utility and have some studies supporting them are myocardial performance, TAPSE, fractional area change, and S prime. Most commonly used are the TAPSE and S prime because of their ease of use. We don't have as much data to support routine use for pressure gradients or 2D or 3D RVEF, RV longitudinal strain or strain rate. So going through our regional measures of systolic function, so our longitudinal strain. So the first and foremost amongst these is TAPSE, and so this is on our RV focused view or four-chamber view. We use M mode along the lateral tricuspid annulus, and you need proper alignment in this view to try to be as parallel as possible to the lateral RV annulus. And you're looking for excursion from diastole to the end of systole. Abnormal is considered less than 17. This is very angle dependent, and so if you don't actually center your LV, it can be underestimated. It's partially representative, again, of global RV function, but there's been studies demonstrating that it has good correlation with radionucleotide acquired RVEF. And so, as I mentioned, the lower reference range is 17. And another important thing to note that I'll just highlight here is with respect to how to measure. There's different ways of measuring, but it's generally the vertical height from diastole to systole. And so often some operators may try to use this length here. And while that closely approximates it, think about the Pythagorean theorem, a squared plus b squared going back to like basic math, c squared. It may differ slightly. And so it's important in those borderline cases to actually do a vertical measurement. When the patient's, TAPSE is completely normal, then in those cases, it's probably not as useful. But when it's borderline, it may be useful to consider just a vertical measurement. Next is the pulse tissue Doppler S prime. And so this is where you're pulsing along that lateral annulus. And you want to be, again, as parallel as possible to the RV free wall. This also has been correlated against radionucleotide established EF. And it correlates with other measures of global RV function. It's very easy to get for the most part, but again, very angle dependent. It may not be accurate in somebody who's had a prior thoracotomy or thromboendarterectomy, pulmonary thromboendarterectomy, or heart transplant. But generally, the upper limit of normal is 9.5 centimeters per second. So anything less than that should raise your suspicion. Global longitudinal strain, as this is used less commonly. Again, it's not routinely recommended by the ASC. But essentially, you're looking at strain average over 3 segments. And this first image here, in the RV focused view, strain is going to be sort of the percentage change in the myocardial deformation, and the strain rate is described as the deformation of the myocardium over a specific period of time. And so this is, again, angle dependent. It does have some prognostic value, but there's not much normative data. The general limits that I've seen described are anything less than negative 20% would be considered abnormal. Now moving on to our global markers for systolic function. So 2D fractional area change. So as we talked about earlier, when we get those areas, they're not useful for us to be able to calculate our fractional area change. And so the way we calculate it is by taking our end diastolic area, subtract our end systolic area, and then divide it by our end diastolic area by times 100%. And so the cutoff for this is 35%. So this reflects more of our radial and longitudinal components, but because it doesn't include contribution of EF from the RVOT, it's not as good of a measure as perhaps RVEF that might be acquired by MRI, but it does correlate reasonably well. This is myocardial perfusion index, and there's 2 methods to acquire this. With respect to the pulse Doppler method, you pulse at the level of the tricuspid valve, and what you're essentially, the philosophy behind it is that you're looking at the non-ejection time period, comparing that, it's a ratio of the non-ejection time period to the ejection time period. And so you're essentially taking this period here, which is the tricuspid closing to opening time, which starts at the end of the A wave and ends at the beginning of the E wave. And then you also then pulse at the level of the pulmonic valve. And from here, you're able to get your ejection time. And the ratio between these gives you your MPI. This is less affected by heart rate. You only need a single beat recording, but if the RA pressure is increased, and if we go back to this formula, the non-ejection time period includes your isovolemic contraction time as well as your isovolemic relaxation time. And if your RA pressures are significantly elevated, that can raise your isovolemic relaxation time, and that would ultimately falsely lower your MPI. The other way to do it is to pulse tissue Doppler. So you basically put your PW signal at the level of the lateral annulus, and here you're able to acquire measurements to be able to estimate, again, similarly, just going back to this formula, the isovolemic relaxation time and the isovolemic contraction time divided by your ejection time. And so a normal value for the MPI using the prior method would be 0.43, and using the pulse Doppler method, it would be 0.54. Moving on to 3D RVEF. So you get a 3D data set. It's acquired for a multi-beat RV focused 3D view, and then those subvolumes are then stitched together in a 3D model to be able to produce this image here. And then from this, you can get your EDV, your ESV, your stroke volume, and your EF. Now, this correlates reasonably well with CMR, and it includes the outflow tract, which the fractional area change does not. But it's very operator dependent, and there's not a lot of normative data, hence why it's not done routinely. And the ASC doesn't recommend routine use of 3D RV. This is in the 2010 guidelines, but it's not in the 2015 guidelines. But this is kind of first described by Gleason and Braunwald in 1962, where it essentially looks at pressure gradient in the RV, specifically looking at the TR continuous, the CW wave. And what you map out is you try to find your pressure gradients at 1 meters per second and 2 meters per second. And the corresponding pressure gradients are described here. So at 1 meters per second, in this particular image, it's 4 millimeters of mercury. 2 meters per second, it's 16 millimeters of mercury. And so then you're able to then calculate the delta between that would be 12. And the time frame during which the velocities increase from 1 to 2 meters per second, in this case, was 0.03. So your dP over dt would be 400 millimeters of mercury per second in this case. And so this is kind of a physiologically intuitive, but obviously you need a TR envelope for this. Generally it may hold true for some patients, but they may not be applicable for patients that you're not able to get a TR jet for. And so anything lower than 400 is considered likely abnormal. But again, this was not included in the 2015 update with respect to measurement of the RV, and so it's not routinely recommended. Going through sort of the normal values we described for the TAPSE less than 17, but what I'd like to highlight is that this is the lower end of normal. If you look at the mean plus minus standard deviation, like 2.4 plus 24 plus minus 3.5, really, most patients in sort of that normal distribution are going to fall really high, still higher than 20. And so even when we're doing our measurements, if we get measurements up to 2.9, sometimes we try to bring it down or make it make more sense. And so I find that it's helpful to kind of think about what the actual mean plus standard deviation is. For the pulse Doppler S wave, less than 9.5, fractional area change less than 35%, strain, as we talked about, negative 20%. For the 3D RVEF, 45%. We already talked about our MPI, and the other measures we haven't really talked about yet. So the general conclusions from the ASC were that, yes, visual estimation is good, it's helpful, but it's likely insufficient in cases where things are discordant. And so that's where simple methods like fractional area change, TAPSE, pulse S prime, and MPI can be incorporated into your routine assessment. And then combining multiple measures is helpful because that can help you to distinguish normal from abnormal function. I just wanted to touch a little bit on AI. There's tons of stuff out there about AI, but I thought these two things were, these two particular studies were relevant and kind of neat to focus on. So the first one was published in Circulation. It was an abstract, so it's still, I think, an ongoing study with respect to this AI technology, but they were comparing RV assessment by TTE to cardiac MRI, and they were essentially getting continuous measurement of the RV wall, endocardial wall, throughout both systole and diastole, and they were able to measure fractional area change, free wall strain, and TAPSE. and compare that, you can see the chi-squared p-values here compared to cardiac MRI, and it correlates roughly well with cardiac MRI. Sensitivities are reasonable. Obviously, it's not very specific, but I'd like to point out that the technologies are ongoing. Like these are things that we'll see in the next 10 to 20 years, is how AI can enhance and improve our ability to be able to get adequate quantitative measures of RV systolic function. In addition to that, this was something else that was published in JACC, looking at how artificial intelligence can be used to precisely assess RV function. And so they basically use this AI technology. It's called EchoNet RV, and they trained it using 7,000 echo videos. And it was able to use both spatial temporal convolutions and semantic segmentation to be able to get higher resolution images from even what the operator had got on the first occasion, and then acquire measures of RV function. They didn't really provide quantitative data with respect to how well it performed, but it was sort of a pilot study to see how this would perform as sort of a machine learning opportunity. I just kind of wanted to highlight a case. Some of you may have been involved in the case, but so I don't want to spoil it in case they're going to discuss it at CICU rounds this afternoon, but more so for the echo value of it. I think it'd be useful to kind of look at. So this patient, I won't give any demographics or history, but just looking at it on first glance, we can see that the RV looks reasonably sort of enlarged in the proximal RVOT. Here, it was measured at 3, so sort of borderline enlarged here in this view. But again, as I mentioned, it's very operator dependent. Depending on your angle, you may get completely different measures. But just visually, you can tell that that's big, just on the rule of the thirds. Here in your outflow, you can see just visually the RV flow tract. You can see the PA looks reasonably enlarged, but again, there's some fuzziness that prevents you from really getting good measurements there. This is your inflow view. You can see the RA significantly enlarged, the RV significantly enlarged. I didn't include any Doppler so as to not obscure anything here and confuse us, but here at the level of the short axis, you can see, again, I just put this measurement in here myself, but this was quite enlarged. It was above 3 centimeters. And so as you remember, the normal would be 2.7 in this case. And then here, you're above the level of the pulmonic valve. It's a little bit obscured, so you want to get a better image to be able to assess that RVEF flow. In this view here, you can see the distal RVOT a little bit better and the PA a little bit better, and so you would be able to get some measurements here. And then you can see here the PA significantly enlarged in this view, and even your right and left PA are significantly enlarged, and so those are measured. You guys can see the measurements, but 3.7 for the main PA, 1.9 for the left, and then 2.1 for the right. So here, what do we see? Shaped septum, here, like, think about the crescent tear shape of the RV here, significantly enlarged compared to the LV. And then this view here, a little bit off axis, but we're able to see our RA, RV. You can see compared to the LV significantly enlarged. And so this would be a reasonable place to get our RV basal diameter in mid. Maybe a little bit challenging to get our longitudinal diameter, but we can get a measure of our RA size here as well. This is the TAPSE for the patient. I just kind of threw in an arrow there just to show the vertical measurement, but this was calculated at 0.8. Our S prime was 5 centimeters per second. The case conclusion from echo: patient is severely dilated RV, moderately reduced RV function. Again, some of the things we talked about here: the D-shaped septum, the TAPSE being 0.8, S prime 5.3, RV basal diameter is 4.9. Our RVSP was calculated. I didn't show the TR jets, but the RVSP was calculated at 80. And then the patient's right heart cath that was done. You can see the echo actually performed reasonably well here. The RVSP correlates roughly well to what we see with the RV and the PA. But notably, obviously, the RA pressure is elevated, but the EDP is normal. The patient's index was low. There's no step up in the saturation, so not suggesting any sort of shunt. The transpulmonary gradient is 52 and the PVR was 20. So I've never seen a PVR of 20 before, but I think this will probably be discussed at some point, but I don't want to spoil. But if somebody have like a diagnosis in mind in this case, or a potential diagnosis. Like primary sort of group 1 pH, and so I don't know, or Chai, are you guys going to talk about this later today, or? Oh, the journal. Okay, sounds good. So maybe you could talk about it a little bit if you want. I don't know the patient as well, but.
Yeah, this is a young patient who's in ICU now. She's 31 years old, and she came in with thermometry dyspnea.
They won't be able to hear you.
Yeah,
Just talk a little bit louder.
So this is a 31-year-old female who's in CICU now. She has no prior past medical history. Was just referred to an outpatient cardiologist with worsening dyspnea over the last 1 to 2 weeks, and they did an outpatient echo in outside clinic, and she was found to have very large pericardial effusion, as well as signs of pulmonary hypertension with RVEF 70 the outside echo. And she had moderate severe secondary tricuspid regurgitation in that context. And so when she came in with worsening dyspnea, she was quite hypotensive, hypoperfusion, with lactate at 7 or 8. And so they weren't sure if this was all related to the large effusion, tamponade. Oftentimes, if you have right ventricular dilatation and pulmonary hypertension, you don't always get the signs of echo of tamponade that you otherwise see. And so to remove that as a potential confounder, and you're doing pericardial synthesis, just draining. And we got this echo that Shamon showed you today, the following morning. So you can see clearly there's no residual pericardial effusion there. It was all removed. Subsequently, we can see how large the right atrium and the right ventricle is, and the degree of pulmonary hypertension that the patient has. And then when we did the right heart cath, you can see the pulmonary vascular resistance is extremely high at 20, but the wedge pressure is 2 or 5, so it's all pre-capillary, which is in keeping with pulmonary arterial hypertension, which would be group 1. So now the patient was started on sildenafil, which is actually doing quite well. Lactates around the legs.
Those are my references, and happy to take questions, comments, feedback.
So thank you, Shamon, for presenting. It's very good at your level to be able to review that for us, and it's always good to have ourselves reminded how to do that. So any questions from the audience? Comments from the sonographer? It's like very much on your side in terms of scanning. Any tips or tricks?
Yeah, thank you for this talk. Like, you often talk about RV, but like, on part of I think sonographer, we don't spend as much time assessing the RV function or as much as we do with the right side. So just comments, because oftentimes we assess the RV function, we only depend on the TAPSE, but we tend to not look at it as a whole, assessing the RV function in long axis and short axis. And apical 4, sometimes we have to modify the apical 4 to get a full view of the RV lateral wall. And then some of us may focus on RV, zoom on LV to check for function in short axis, for start on short axis, and then we cut off the RV. And also in apical 4, if it's like a TDS patient, we only focus on the base. So we get like a TAPSE of 17 or more, then we call it as normal. But in overall, we don't see the mid and distal part of the RV lateral wall or the free wall. And then the next time when the patient comes, and then you look at it as, oh, it looks like not a normal RV systolic function, and then you go back to the previous. So, I mean, would I say, say, if it's me scanning, would I say, is there a change from the previous or no change from the previous? But then when you look at the images, they're kind of the same. So I think we just tend to spend more time on LV function, and then we kind of like not spend so much time on assessing RV function. And also a comment too, when we're doing like TDI on the right side, we tend to cut off that E prime and A prime, which is also like good in assessing the systolic function of the right side, right? We thought that we're only assessing the systolic function of the right side, so we just care about like taking the S prime, but then we cut off the E and A, which is also like I think we should also kind of like not to forget that it could also tell us about the diastolic function of the right side. So I think it's just like more of like for us on the sonography part, like we at least we could spend more time assessing the RV, because you could tell from the previous, if you look from the apical 4, you only have one shot of the RV for function, and then that's it, you move on, right? But if you are assessing more of the RV function, you're spending more time, you would know, like, the sonographer would tend to get more images, like, for shortened or like modify it, like you go more medial to modify to check for your TR, to check for your RV lateral wall, like, from base to distal. And then in short axis, you go all the way to the apex. You can also check the RV apex. So it's just more for us, like a sonographer, like, to give time as well on the right side, not just the left side.
Yeah. So maybe if I can add to that, I think it kind of goes to the general rule that you don't rely on only one or two parameters. Just to use the full study to make any assessment. And I think we're good at doing regular TAPSE and RVS prime, but we can't rely on those solely to assess RV systolic function. There are times where they'll be normal, but the RV free wall is hypokinetic or akinetic, for example. Most times it's global dysfunction, but a lot of times it could be regional. And there are times where it doesn't really reflect the RV systolic function. So classically, post-pericardiotomy patients, bypass surgery, valve surgery, the basal parameters will be reduced, but you can see the RV free wall is contracting normally. So you have to make a call that overall RV systolic function is normal, but the TAPSE is not reliable in that circumstance. And there are issues where the TAPSE is abnormal, but the angle is poor, or it's just a poor image. And then we rely on our global assessment, but you can't always rely on your global assessment. So you have to understand the caveats between the two. But there is some reliance on focusing on the TAPSE and the RVF prime sometimes. I do that as much as anybody else, but if you're going to call it based on that, just make sure everything else kind of fits within that overall.
So regional wall motion is actually very important in terms of assessment, in addition to just looking at the TAPSE and S prime, the systolic function. We seldom do a fractional area of contraction or FAC because it's highly variable. So to be able to get a good view, I think having the RV focus view is really important. So make sure you have that for us to help looking at all the wall motion. Just want to bring in the historical context of this RV chamber quantification guidelines. So as you know, it's actually Canadian. So I want to make sure that you're aware of that. So why is it Canadian? So the story goes back to the Jewish General Hospital, where there's a professor called Dr. Langleben, who was my teacher, and he had a very, very long interest of pulmonary hypertension. He had a student called Dr. Lawrence Rusky, and who later on become the CSE president and also the head of a Jewish General. He proposed the guideline to the American Society Echo. At the time, there was a long time that we actually don't have any criteria for the left side. Even after Dr. Roberto Lang from Chicago has come up with the left-sided guideline. So the right side become, or was still remaining a no person's land. So with that proposal of the guideline, it put the right part actually on the map, so as to say, we now have more consistent way of assessing it. The RV focus views was introduced by that paper, and thanks to our Canadian contribution, we were able to do that. And also, he involved another epidemiologist from the Jewish also to try to look at all the cutoffs. The BDSMA, the problem with right heart at the time when it was published, there were not a lot of papers of normal. So it still remains quite a challenge. So as you know, in the right heart chamber quantification guideline, as opposed to the left side, so it's actually not very much petition values. So we report mild, moderate, or severely dilated right atrium, or mild, moderate, or severely dilated right ventricle. Actually, this cutoff doesn't exist still. So I think that remains to be another area of development, because like most of the time we say yes, this is abnormal, but then the actual petition part of it is very subjective still. So we're still in that period where it is. So it's really worthwhile these days to acknowledge all the Canadian contribution.
And I think the updated right heart, I think it's still in the works in the Lawrence system.
Yeah, he's working on it.
With that, and on top of that, the overall chamber quantification, the target for that is January 2026. So we have to wait another year for that one. But I think the right heart will be out either around the same time or before that.
Yeah, I think they're going to integrate, like, in 2015, the right heart chamber quantification guideline was absorbed into the overall chamber quantification guideline. It was actually separate before that. So now they're actually working on an updated version. Typically, it's about every 10 years they get a new one.
Yeah, but I think there's a separate right heart one as well.
Okay.
That Lawrence was co-chairing with a young,
another lady doctor.
That he was trying to tap as well.
Yeah, so it's a lot of work. I
expect that'll be out.
So they're still working on it.
Yeah. Well, they're going to incorporate the WAVE data, right?
Yep.
So.
Question practically, let's say that you actually do a good quality echo and due to the best of your ability, taking all the views that we're supposed to, like of all the not so reliable measurement, what is the most reliable person, sonographer, intra observer measurement, if there is any?
I don't think there's one specifically. It all depends on the images, the image quality within each views. And ideally they should all fit together. Sometimes they don't, right? Like it's not uncommon when the RV looks dilated on the partial views, get the epic views, they all look normal. And then you're kind of stuck, and you have to decide which one you lean against. So get some clinical context, etc. And then you go to which is bothersome.
I'd probably pay more attention to the four-chamber view, frankly, but you're right, it can be difficult.
No, it can be, and that RV focus view is very challenging.
Well, we all know RV has two parts, inflow and outflow. We only report the inflow. Sometimes we see isolated, dilated RV outflow. We never really reported that, or we don't report that.
Yeah, it's pretty uncommon actually. Like practically, if you see the RV dilated on the parasternal long axis, like it's a standard view. It's not a low parasternal view. Usually, by the time the RV outflow tract is dilated, the whole RV is dilated. Maybe a few clinical conditions where it's potentially not the case, maybe appearance of ARVC, for example, but in general, once it's dilated in the parasternal, it should see it everywhere. So.
Yeah, the RVOT is making a comeback in Europe, as previous presentation has commented on. Like for a long time, we actually ignore the RVOT, like in the parasternal long axis view in that RV piece. We said, yeah, it's not very reliable. It's like, it depends on how you image it, but it's actually making a comeback in the European guidelines. So I think, getting a standardized all lined up view is really important for the parasternal. It's a great screening way to look at it. If it's really big, it's really big. And if it's not big, it doesn't eliminate that it's not big in the other views.
It kind of gives you if three like true 3D RV assessment, that's what's a good quality, that's accurate. That would take everything out of the equation, right? That's with the ideal, right? But obviously, they're still struggling a bit with the LV 3D quantification. So the RV is going to have to wait.
The one wall area that I'm not sure we look at enough is in the setting of inferior infarction. So when the inferior basal wall is on the LV is abnormal, make sure you look at the posterior wall of the RV, and that it basically you see in that short axis view, because I think it's often not normal and we ignore it.
No, I agree with you actually. You know, classically you look for that. It's the T abnormality, right? The septum, inferior wall of the LV, and then the inferior wall of the RV. And that's where the subclassic view helps. So when you see the subclassic view and you look at that quote unquote RV free wall, that's actually the inferior wall of the RV, because that's the RV next to the diaphragm. So that's the inferior posterior wall of the RV versus the anterior wall of the RV.
So Shamon, can you go to the short axis? Just want to point that out. So historically, this is actually from Mass General, from Dr. Levine. And because we were in Boston, so that was actually known as the T sign, as in the subway. So it's do you have the short axis model of the RV?
At the papillary,
Yeah,
or
at
at
the
the
papillary
microvalve level.
Yeah. So what we have been talking exactly. Yeah. So we can point it out. So basically, it's the inferior septum. Yeah, when you have an inferior infarction or RCA infarction. So and yeah, they're close to that. Yeah. So it's the inferior septum, and then the inferior wall.
Actually, a little. Usually, it's closer to the mitral valve. The
Yeah.
basal inferior, so one up. There, the bottom one.
Yeah, and then the
Right there.
inferior portion of the RV. You can circle that on the screen. It looks like a T upside down. So, but if you are from Yale University, it will be the Y sign. It actually looks like a Y as well, as in youth. So this is actually a very useful view. I look at it all the time because the way I was trained, we were asked to look at that all the time to report on the involvement of the inferior wall of the RV. Yeah, that was a good point. Yeah. So any other comments?
Just a question. Like, in measuring the RVLT, where is the best view? Is it in the RVLT or the short axis?
So yeah, you can technically do both, but I think at least in the ESC guidelines, they say they're doing short axis, but you could do it in both.
Okay.
For at least for the slower RVLT. But here, if you're able to get it in the same view, then it's kind of nice.